a lot of rural and urban locations in Washington, Oregon, California, and Hawaii too. So our panel members, I'll let them introduce themselves.
Good morning. My name is Ryan Rothaker. I'm with Duke Realty. I oversee our medical office building, property management and leasing around the country. We own about 85 assets, 6.5 million square feet, valued at about $2.5 billion.
Vic Schmerbeck with Ameris. We are a micro-hospital operator in partnership with leading health systems. So we have, there's a portion of this that, and I know over the last year there's been a lot of talk about micro-hospitals. We've been in the micro-hospital business for about 8 years and are fortunate to have great partners like SCL Health in Denver and Baylor Scott and White throughout Texas, Dignity Health in their markets, and many other, Baptist Health System, many others. So I'll spend some time talking about our initiatives on the micro-hospital side and how it affects kind of outpatient delivery for systems at large.
Good morning. My name is Peter Kung. I'm the System VP for SCL Health. SCL Health is a 11 hospitals system, soon to be 13 when the other 2 micro-hospitals come up. We are $2.5 billion in annual revenue, and we serve 3 different states: Colorado, Montana, and Kansas. I'll be complementing what Vic will be speaking about in terms of the micro-hospitals, and I'll be complementing that with our virtual health efforts.
Thank you. So I'm the switch hitter moderator for today. Kevin Kern, who had to leave because of the hurricane that's hitting Florida. So Godspeed with him, and I know a lot of other people probably who had to leave early for that. So bear with me. I just got some of the details this morning, so we'll power through it. But my part is going to be on telehealth. It's a big initiative that we're looking at here in Southern California. And that takes us to, so here we now feel it's cheaper to do surgery via Skype. So go home and lie down in front of your computer. I think, the dynamics of telehealth as we look at it, it's very new. So it's hopefully that's not where it's going to go. Some physicians are really on board with it, and in our marketplace, we've really seen a lot of consumers who have really gone to that area. But so I'll start with kind of the big picture setting. The CMS Administrator Don Berwick started using the term triple aim, which is better health, lower cost, and better care. 6 years since healthcare reform, and we've seen it irregardless of what your opinion may be on healthcare reform and how it's affected the marketplace. It's still a very big factor. In our marketplace, we serve a lot of underserved areas, and so we've actually seen it benefit a lot of our population. It's been able for them to receive care a lot earlier. It's really changed the reimbursement landscape. Providers now, though, are having to take more risk. There's bundled payments, there's capitated payments, so it definitely has changed the dynamic. So we want to look at these some of these global shifts, how it's affected. It's probably driven a lot of the changes, and also too, to a certain extent, the facility and what some of the facility requirements are. So as we go through the presentation today, we'll want to close with one predictive on how all the discussion points that we've had today, how this will really affect and what's kind of our view into the future, what it will look in 3 to 5 years. So I'll start with SCL Health. And so Peter, how do you view telehealth? Oh, whoops. Well, let's make sure that we've got the right slides.
I think we were going to go through micro-hospital first.
Yeah, let's go start with micro-hospitals first.
I think everybody has this material in front of them, by and large, or a summary thereof. I guess the good thing is, because we're all partnered on the SCL front, but most of the ones that are under construction involve us, whether a lot of them involve MREIF, but many of them involve Duke and SCL too. So if you want to flip forward, I think there's a map here that talks about, and Hilda, I think, put together some data on what's going on in this, quote, micro-hospital, small format facility across the country. One thing I'd caution everybody, we kind of coined this phrase, micro-hospital, about 7 or 8 years ago, largely because we as a team were going around talking to health systems about building really small access points. And most of the discussion was, what does that mean, 50 bed, 100 bed? And we kept saying, no, smaller, smaller, smaller. So we kind of coined this micro-hospital phrase. But I think in today's world, it has a different meaning to different people in different states. So when you look at this state map, don't think it's one size fits all, would be my general take. Sorry, I can't do it myself.
Sure.
I think we can bypass that as well. This is, relates to, this is an advisory board piece, or it's an excerpt of something the advisory board did earlier this year about the health system of the future, and one of the initiatives was around micro-hospitals. I think the real takeaway is it allows for, and I'm going to show you some pictures of some of ours, it allows you to, at a lower cost, get into and fill access gaps in the market delivery for a health system. So here in Denver, in the greater Denver area, SCL has a predominance in the center and north portions. We're expanding their footprint by going west and south with the idea that you're not building additional big bed towers for centers of excellence like neuro and ortho and cardiac, but really creating a great place to serve patients in the communities where they live for a lot of their services and getting them to the higher point of care when necessary. Telehealth will ultimately play a part in this as well. But the micro-hospital at its core has a small number of inpatient and observation beds, an acute episodic center, and then co-located other services based on the trade area demand. So primary care, rotating subspecialty. In some of our facilities here, we have, there's a dedicated endoscopy suite. We have ORs in the facilities here. In many of our other markets, it's a combination of what's the need in the marketplace. If you sat through the previous presentation, Wendy was talking about the data and the strategy around it, and then you look at that map nationally. Our belief is you can do this in really small formats and really capital and operationally efficient models, not trying to build for what may be 20 or 25 years, but building for what's today, understanding that if the population grows in that period of time, that you can build another capital and operationally efficient model to fill yet another access gap, that you don't need to try to do it all today. And with the movement out of potentially with inpatient services diminishing inside of the big tertiary facilities, that there will continue to be capacity in most markets. So then it's a question of how do you create and here what other outpatient clinical services that would be co-located and branded inside of the facility. So this is the outside. I should have put an SCL picture up. Sorry. This is the exterior of one of our facilities in the Dallas-Fort Worth market with Baylor, Scott and White. It's a 2-story facility, much like our facilities here. The first floor is the micro-hospital. In this particular case, it has 8 inpatient beds, a similar number of emergency treatment rooms, lab, radiology, pharmacy, dietary, CT, X-ray, ultrasound. And then on the second floor, it has Baylor-affiliated primary care, rotating subspecialty. I believe in this facility there's pediatrics and outpatient rehab, PTOT clinic.
So you took this picture on the one day of the year that it snows in Dallas?
It's exactly. So I want to talk a little about the care continuum and leave everybody else time. If you'll flip ahead. So here is what our vision in terms of what the micro-hospital can be to a health system and to the community it serves. The green line is inside the micro-hospital. So you're dealing with ambulatory procedure center, community hospital, pavilion, and you're not really, in most cases, getting to tertiary care. We do have general surgery and other OR things in some of our markets, like Denver. But if you think about how do you best utilize an existing fixed asset to serve the community, and you start thinking about the yellow lines in the sense that you can co-locate other services and still maintain a really tight footprint, by co-locating primary care, we have most of our partners with their primary care in the co-located locations also have extended hours. So you're enabling people that are maybe walking into the ED that don't really need to be in the ED to be medically screened and appropriately sent to a primary care physician, rather than having the back-end experience of getting a facility bill and a pro fee and a bunch of other sticker shock when they get their bill. And as you move more to, taking risk and bundles and other things, the more you can get out of that fixed asset alleviates the need to build more brick and mortar for, be it retail pharmacy or urgent care or other aspects. You can co-locate. It's not the end all. It's not the only solution, because it still is a bigger format than a physician clinic or something else. But it enables you to direct and get that patient to the right place the first time. One of the things that we've been talking about is you can take that one step further with telehealth and have even a kiosk in the lobby that would allow someone to even get the lowest level of care in terms of they don't even really need to be in a primary care office, but they've walked into a facility because they say, I know if I go there, they're going to get me to the right place. And you can put a telehealth kiosk in there. Further, when you start thinking about specialties like pediatrics or other aspects, in one of our markets, the Dallas-Fort Worth market, where we've built out, we're retrofitting a suite that's going to be pediatric focused, but it's going to be solely tele-pedi specialties. So if you have a pediatric patient and a family that comes in, they can get specialty through telehealth to determine whether that patient truly needs to be transferred to Children's Health or Medical City in the case of Dallas, or can they stay in that facility and feel comfortable that they've gotten the right diagnosis. And then on the back end, on the post-acute side, if you think about co-location of outpatient rehab or other home health services, you can do those things.
Yeah, Vic, can you speak to the certificate of need impact and how the process is different between certificate of need states and non-certificate of need states?
Sure. Not all CONs are alike, I think, as we all probably know. In some states, we were laughing. Some states, no disrespect to California, some states don't have a CON, but they might as well.
It's okay. We're the land of fruits and nuts up there.
Exactly.
No, it's the land of Washpond.
Yeah. So every market is different. So you have, there's 24 states, there's 37 states that have some level of certificate of need. There's 24 states that have CON requirements as it relates to a hospital of this type. So a lot of it depends on the need. We have a big moniker in terms of we're heavy into data in terms of why patients utilize services they utilize, and frankly why they come to a small format facility versus a larger format facility. But you have to go make your case in a CON state in a lot of ways. Not all, and I think we all know this, but I can go in to a market and say on one metric, beds per capita, you're oversupplied. And then I can take the same data and very clearly articulate to you that the beds are inefficiently placed for distributed care. So how do you solve that problem? And I think that's the piece that CON states are going to have to take into account. Unfortunately, I think what's happening in places like Florida and Washington, where CONs are not required for satellite emergency rooms as departments of the hospital, which has a carve out from site neutrality, people are going and creating distribution points that are just an emergency room, which we think is not the most efficient model to deliver for that patient. You end up transferring low-level observation and low-level inpatient needs, and you don't have a way to correlate getting that patient to the right place in all cases. So there's some rationalization, I think, that has to go on in some of the markets. In addition to other, California, the other one is, you have a very strong union for allied staff that has required staffing ratios and disciplines. And when you get into a small format facility like this, I mean, our hospitals are 16 to 20,000 square feet. You can't say, I need to have 15 people in the facility as your base staff like you would with staffing ratios inside of a larger hospital. You lose the efficiency to make it work. So we do a lot of cross-training, a lot of aspects with our staff that enable that facility to, as Wendy put in the previous presentation, pencil out and actually make sense. But it's a process that you have to work through.
And how do you do site selection? And do you see like the growth more in the rural areas, urban areas?
So heavy data on site selection. I think there's a common misconception of the freestanding emergency room and maybe pushing into some operators in the micro hospital that it's much more of a convenience and affluency play. We abundantly disagree in the sense that it's really a community need that needs to be served. So if you think about in old school days, you have a bell curve in terms of, if you go to the high affluency, everybody's going to be insured and commercially insured and they pay you, but yet they use services very different than most communities. They tend to spend more on preventative care or healthier populations. If you go to the indigent side, you can get all the volume you want and you worry about how you can make numbers make sense. So you really have to be in the middle portion in properly serving the community. The unique thing that I think we have from a data perspective is, we have hundreds and hundreds of thousands of unique visits to our facilities across many markets, which allows us to do the data underneath, the correlation data around why do people utilize small format facilities for certain services, so that when you look at a market or a particular trade area in a market, you can better understand how that population within that defined catchment area is going to utilize services as it relates to site selection. But there's clearly a boots on the ground aspect of, the difference between the corner of Main and First or Main and Second, and, whether there's, highways that people don't cross or bridges people don't cross or waterways people don't cross. I mean, there's lots of dynamics that go into it. But from a pure data objective integrity, I think we do a pretty good job of identifying why to put something in a particular area, and then you've got to go really hone down to what corner inside of that small circle. And I don't know, you guys have both been involved with us on that.
Mm-hmm. Yeah, a question for Ryan. So how, as far as the investment, how does that work? And do you have, what type of partners are you having? Health systems, private equity, individual investors?
Well, we've, as a publicly traded REIT, we've self-funded all of the MREIF projects. So I mentioned in my intro that we own about 85 buildings, 6.5 million square feet. Inside that portfolio, we are up to 11 micro hospitals, and it totals about 400,000 square feet. And we treaded the waters very cautiously because your typical investment in a micro hospital is much larger than it is in an on-campus or off-campus MOB. So we're investing upwards of $500 a square foot to own and develop these buildings. But where we got comfortable is we truly believe that this is the future model of healthcare, but also the sites that these micro hospitals are going on is really the main interchange in retail environments. So we've got an exit strategy that if these things don't succeed, we'll convert it to medical office space, and hospitals want to be there. So what Vic mentioned that we see family practice, PT, pediatric services that go into the second floor of these buildings. And of the 11 that we own, we're seeing all of the sponsor hospitals like SCL and Baylor put those service lines in the buildings. So they want to be at these locations, and they want to expand their services in these locations. So that's where we got comfortable with taking a much larger investment in a typical MOB building.
One thing I'd add to that, just because I didn't clarify it, the name of our company is MREIF. The name on none of our buildings with our partners is MREIF. It's SCL Health, it's Baylor Scott and White, it's Dignity Health St. Rose Dominican, it's Baptist Healthcare. We're the core competency we bring is around operational efficiency and site selection and what we do in the small format. But it, at the end of the day, is a branded healthcare destination point for the health system in the market.
And to even piggyback off of that, the majority of our portfolio that we own, we manage and maintain it. These micro hospitals, Ameris manages and maintains those assets. So it's really a triple net, absolute net lease structure with them. And we have confidence that they know how to run a hospital and manage the infrastructure better than we do, so that partnership works. And the other point of clarification for the REIT developers out there is we treat these as off-campus, even though they're licensed beds. We have this debate internally, should they be on campus or off campus? They are held in our off-campus portfolio, and that's the way we treat them. But there certainly could be an argument made that maybe it is a non-campus asset. So,
And I think the health systems, by and large, think of it as part of their ambulatory strategy and
Right.
portfolio.
Oh, absolutely. The micro hospital fits into our overall network and access point strategy, and having great partners to really focus in on a segment and also that community need. For us, I think at SCL, it is, in echoing what your sentiments of Vic, is we believe if you do right with the patient and customer, the economics and the arithmetic is going to work out. So that's our focus as we build out and partner with Ameris.
Yeah, I would agree with that. Is that, you always take a look at the economics, but at the end of the day, it's truly the physician and the patient who will drive if something's successful or not. And so we don't have micro hospitals in California, but I'm curious about the model and kind of the long-term success of that. And so where my question is going to stem as far as, the long-term viability of that back to the physician-patient interaction is that how do you see strategically how the primary hospital and the physicians work with the referral network on that? So
If you flip to the next slide, sorry.
this one.
No, go back one if you would. So this is kind of goes to how do you use, and I think somebody in the previous session talked about how do you get them, we for hundreds of years built a whole bunch of fixed assets. And I think even today we have siloed, at least on the pre-acute side of the healthcare spectrum. For a long time, primary care physicians said, come see me between 8 and 5. And out of that came retail clinics and urgent care and other aspects to fill a need in the community, because patients said, I no longer want or can come between 8 and 5. And I can't afford when I go in there to spend 3 hours in the waiting room and doing all the things I need to do. So we've had a whole industry over 20 years or 30 years that's evolved. I think as we step back and think about it, the end of that is great from a choice perspective. The downside of that is we've now overly confused the patient in the sense that they don't know whether to go to, and frankly, now you throw in doctors on demand and other telehealth things, so you don't know what to do, and we have no transparency from a price standpoint by and large. So we believe you can fix that by creating a neighborhood setting that says to that community, if you come here and trust in our brand, we will get you to the right value place. Whether that be a kiosk in the lobby or a primary care visit or the emergency room. And by the way, if we don't have in this facility what you need from a surgical or emergent life-threatening case that needs to be in a cath lab or something else, we're going to get you there on a basis that's better for you than had you gone to a big campus. And no disrespect to any of our health system partners, they would tell you the same thing. But inside of our micro hospitals, our door to balloon times, meaning door to cath lab table, are less coming to our facility, being stabilized and directly admitted to the cath lab than had that patient walked into the ED of the facility we transfer to. So from a process orientation standpoint, our goal at the end of the day is you get the most out of the fixed asset and you get the patient to the right value equation the first time. And so if that's our whole strategy of creating these access gaps to capture patients, make sure they get to the right place. And then develop a cost structure on the back end that can be beneficial to the system too, from imaging and rehab and other things. So.
Yeah, so are you forming forming partnerships with those ancillary services for the tests and everything? Because, the primary inpatient model is that it's always heads in beds. So we're always trying to drive more patients into the inpatient setting. But within the micro hospital, is the focus to try to, I don't want to use this, but churn the patient out? Because ideally, you want to make sure that it's a better viability for treating the patient to the right service. So are you sending those patients out to other services? And I guess the question I'm trying to get to is there an opportunity later on down the need that's going to drive more of those facility needs for some of those other tests and other services?
Yeah, that's a great question. I mean, every system that we're partnered with is on a different journey to fee for value, if you want to think about it that way. And so we have some partners that are highly progressive from a pricing perspective, and we've been very innovative with. We have one of our partners that we're 6 months into a trial where it's a one bill, one price in the ED by level code. So you're not going to get a pro fee, you're not going to get a bill from the lab provider, you're not going to get anything else. But it's a captive group of lives. The first pilot is 70,000 lives. But transparency, it's not answering your question specifically, but what we're trying to do is we don't think it's good for the patient to be transferred to a big acute care campus if they're going to be holed on an observation bed in the hallway, right? So that's not good for it's not good for the patient. And I think most of our health systems would say we don't want it either. So you admit to the criteria that you can handle in the facility, and that changes a little bit location by location. But what you're trying to have is the right heads in the beds, not just heads in the beds.
And adding to that, I think it's dependent on your strategy outlook, right? If you're looking for surviving for 1 year, there may be, as we're moving to this value-based and capitated healthcare transformation, yes, there needs to be some arithmetic that needs to happen to keep the lights on. Absolutely. However, I think the play at SEL and our belief is, look, we're going to have to move into this new world, and we can't wait 3 years until it happens, and then we start acting because we're already too late then. So there is going to be a balance, and SEL is committed to saying, yes, financially it needs to be viable to keep the lights on. At the same time, it is, you'll see as healthcare moves more into value-based contracts, that we will be taking on more strategies like this to get the right patient where it's convenient for them, affordable, and accessible. So echoing what you just said, Vic, putting the right patient at the right bed, that's more important as I think what we're going to be seeing the next 3 years.
Yeah, so Ryan, I'm going to ask you a question. You've been quiet during this time, but how do you see the long-term profitability? Are you taking a look at that? Are you providing consultation services to your clients, or is it just funding services?
We do provide some really free services. When a MREIF calls us up and we might have boots on the ground, or they want us to look at a site, we'll help them with site selection. But we have to underwrite a little more risk into our rental rates on these type of deals. So there's a little bit of a spread there on, what our development yield is compared to a typical MOB. And then, again, cost is a big issue for us, so we want to cap how much we're investing in the building. And Ameris has been a great partner there where, we come to an agreement on what Duke's cost limitation is, and then we'll offer them amortization packages for any excess costs that our investment committee just can't bear to take on an off-campus asset, even though it is at Main and Main. They are in great locations, so.
He's cheap.
So the focus of the panel today is some of the new models. So we've talked about the micro hospital. So I'm just going to switch gears a little bit to move into the urgent cares. And one of the dynamics we've seen that's really grown, I know it's sometimes in some of the conferences I've been to, Walgreens has been a speaker. So as far as the minute clinics, so Peter, I'll throw this question out to you, and then I'll answer too, is that how is the large health system, do you see, are you looking at any partnerships with the Walgreens, the CVS's, their minute clinics? Do you see them as competition, something that you partner with, or just kind of leave them alone and let them do their own thing?
Absolutely. Well, when I was at UCLA, we partnered with the CVS Minute Clinics around that as well. I think it goes back to this confusion of what's happening to the patient, right? We're throwing a lot of access points, and we're not really good about, one, educating them, two, doing that clean handoffs. And as the consumers are getting into high deductible plans, we know they're a force to be reckoned with in terms of we have to really own that relationship and make sure that they're getting the appropriate care at the right time and the right price. Now, my concern, or not concern, it's this. We're going to see traditional and non-traditional competitors coming into the market, right? You got Googles to the Walmarts, and if 10 years ago you said to a health system, Walmart's going to compete with you, we would say that's unbelievable. But they're saying 1 million people walk through their doors, and we could move and influence what's happening in there. The thing that I would like to see is that we don't fragment the system even more. And so if I would see tremendous value of a partnership or a health system partnership, or there is no partnership with the Walgreens and all these minute clinics, if we could actually do cleaner handoffs. And I think that's, as SEL investigates in terms of our portfolio, it's about these partnerships that you can do a better handoff in delivering a better experience for that patient so that they could get better.
Yeah, I completely agree with you, Peter, is that, we both, so if you worked with UCLA, I'm in the Los Angeles market, it's probably one of the most fragmented marketplaces in the United States. There's no individual strong corporate player there. There's several large systems, there's several individual hospitals. So your comment about the fragmentation is completely true. I mean, there's always a struggle to make sure that we're communicating to the patient exactly where they receive that best level of care. At least in our local marketplace, we do have some CVS's. We actually have one that's literally 500 yards down the block from one of our urgent cares. And where we've seen them is that they're great for providing the initial entry if a patient's sick and they really need medication. But it still comes down to being able to provide that really high level of quality of care that they're unable to do. And it's interesting because we've had several comments from some of the patients who go to the quote-unquote minute clinic telling us, oh, I was waiting for 90 minutes, so I just walked up to your urgent care and I was seen in 5 minutes. So I think there's still where the large system branded urgent cares or rapid type care clinics can still provide that higher level of care to the patient, and ultimately I think that's still important. So I'll be interested to see, at least in the Los Angeles market, the future of that type of level of care, because the patients are very savvy, they're very smart, and if they're having to wait for a long time to get a lower level of care or the same price of care, they'll probably still switch to the larger systems.
Yeah, so one thing I'd add to that point, and piggybacking on what we were talking about before, I made a comment that micro-hospitals don't fill all the void, right? And they clearly don't. I think what we're saying longer term is where we have a micro hospital with SCL here, there's not a need to also have a retail clinic and an urgent care and other things that you're building more bricks and mortar. And so how do you take what's already built and use it across the entire continuum? So again, if it's an APP, a mid-level for a Z-Pack, or it's somebody who has chest pains, they can be served and they'll be, and I'll go back to the pricing scenario. I talked about the one bill. We've priced that all the way down too. So if you're a level 1 or a level 2 walking into our ED, it doesn't matter for that captive set of lives. You're going to get charged as if you went to, it's a $100 visit. There's no facility fee. That noise is out of the system so that you can, now it doesn't mean that you don't need to go replicate other distribution points, but you don't need to have all of them in one place.
Yeah, one of the things we're looking at with our urgent cares is the idea of having medication management. So of course they are going to go to the CVSs, to get their medication, but at the same time they don't have a kind of warm handoff to what they need to do. So in our urgent cares, if we can manage those patients post-discharge, it's much better that we can send them to our brick and mortar place to make sure that they're receiving their medication. So a lot of the critical care, the patients, the cancer care patients that need to be treated, so we're able to take care of them, so to keep them out of the ED. So we'll just send them to our urgent care rather than send them to the physician.
And there's models out there right now on retail delivery for pharmacy too, where you can, at discharge out of one of our facilities with our partner, that patient can say, okay, your medication's going to be dropped, you'll have it in 2 hours at your home, where it alleviates another stop, or even putting a pharmacy in the location as another way to get more out of that one fixed asset.
Mm-hmm. So I think that brings us to telehealth, and Peter, I'll move to your slides. Do you want to kind of bring us through?
Yeah, we'll go that's one slide before, right after that one. That one. So telehealth, we call it virtual health here, and there's a lot of ways to say it. Telemedicine, telehealth, mHealth, digital health. We just wrap that under one umbrella called virtual health. And it's a really simple concept that we believe, or I believe, that you could deliver quality health regardless of geographic location. And as our healthcare industry is undergoing massive transformation, the more transformation in the value-based care, the more of these strategies, such as virtual health that's complemented of micro hospital access points, that this is going to grow. I would add just to highlight the virtual health aspect, I want to add another layer or lens on this. And we have Ian Morrison, who's a healthcare futurist. Healthcare has one of those as well. And what he's saying is, as we move to this, what we call the second curve, it's underlying sneaking suspicion, whether it be margin, growth, revenue, that there's going to be a radically new way of doing business. And we agree that it's going to be there, but we're all trying to figure out how to get there. And in particular, the internet and what it has done to many industries, but largely unaffected to healthcare. And what does that look like? And so we talk about the blockbuster parable. And the blockbuster parable is in 1997, there was an individual who had a late fee because of Apollo 13. And he didn't want to tell his wife, and he was working out at a gym, working out. And he says, why couldn't it be, this blockbuster model look like, use it or lose it kind of, you could use as much as you like and then go away. So he was relatively successful because he just sold his previous company, so he had some time on his hand. And in the year in 2000, he approaches Blockbuster and says, I have this new product, and I'll sell it to you for $50 million, and I'll run it for you. And this individual, what happened was he was laughed out the boardroom. This individual's name was Reed Hastings, and he was the founder of Netflix. And what we've seen in the massive coming years, in 2004, Blockbuster is running high, 6,000 stores, $6 billion in revenue, 60,000 folks. And in 2010, files for bankruptcy. And then I just checked the market cap on Netflix today, and it's at $45 billion. So the question is, though, are there any similarities, right? Does this remind you of anything? Your customers don't like going to your physical place, stores. They don't actually have a great experience, and the billing is just confusing because in the year 2000, 16% of Blockbuster's revenue is tied to late fees. Does that remind you of any industry that we may be involved in? And so we take this, and we got to radically shift how we're going to be looking at the healthcare transformation. If we go to the next slide. I like actually your slide, Vic, at the end, because I think this is from SU2. It goes back into the home. And one way of thinking about how virtual health complements strategies across the board, from the community-based care to acute to post-acute back into the home, is just do this mental exercise. Get rid of the concept of a discharged patient. Get rid of it. What does that mean, though? Right? And that patient is our patient, in our four walls or outside our four walls. And so how, I'll go to the next slide because I know we're running short on time. If you want to click through that, it's going to, what SEL is saying is this. You know, you run through the hospital to the home to ambulatory clinic, and it goes back and forth, right? And we want to put all these different initiatives, and they're not point solutions, because this is what, when I speak with our fellow associates and our leaders and different care sites, which are our hospitals, you just got to put the right lens on this. And it's a very simple lens. And all it is this. Treat every patient as if they are your own family member. Because it starts making sense then, right? Because if you're at the ambulatory, if you have a cold cough, you don't want to go in the snow and wait 3 hours and things like that. Yes, you want to be able to, on the tips of their fingers, be able to hit the smartphone, and that's the appropriate place and setting of care. And yet they know that it's tied to a physical health system when things get worse, right? And so how about they are at home? We spoke about ONC. How about that patient going back and forth? Sometimes they're really ill. Imagine that's your own family member. Wouldn't you want to know that the care team is able to monitor, be able to make sure that, hey, we see something happening and now you really got to come in? Or when it's appropriate because you're homebound and too sick, that we could still communicate and we could still coordinate care. But how about you do land up in the hospital? Well, when our specialists are running around, right? There's a physician shortage, all that, and they're geographically restricted. But wouldn't you want to know for your own family member that although a specialist is running around and maybe at different parts of the state, that they're able to beam in and give that second opinion and start doing that course of action? That's where we see virtual health as going to be strategic to where we're thinking healthcare is going to go. And it's a very simple concept that we don't want to separate virtual to physical. It's complementary. And once you look at initiatives and you see a lot of venture capital going into it, it's a very simple thing as we evaluate. Treat it as if they are your own family members. And how would, if so, and it delivers that value, how do you coordinate across the health system, though, that these handoffs or the care coordination is seamless for that patient? I'll stop right there.
Yeah, I think, so I'll take the next part into telehealth because it's probably one of our major significant strategic initiatives that we're looking at into 2017. And when you talk about the telehealth, whoops. Oh, great. It's that's great when PowerPoint starts to move things around. So for us, we're looking at it into different buckets. I think it was initially mentioned as telehealth is a lot of things right now. So really, what is virtual health, telehealth? How we're looking at it is that there's 3 different buckets. We're looking at direct to consumer, and that's simply where a consumer picks up their phone, they have a sniffle, they have a cough, say, how do I take care of that? And that's the idea of the Minute Clinic. So, because a Minute Clinic doesn't provide all types of acuity of care, So the virtual health right now, the telehealth, direct to consumer, is very simple things. I need some medication, I need to be taking care of this real quick. So what I have down here is just the key things, the physician integration, you have to look at the technology investment, and that patient adoption. And what we've seen in the direct to consumer and some of the partners that we're looking at, there's this idea of this is the next greatest fad, and it's a lot of millennials using it. Does anybody want to take a guess what the average age of the consumer is using a telehealth application? Yeah, you're close, 45. So one of the primary partners we're looking at, they had patients, a lot of patients were in their 50s. They had the 90-year-old patient using it. So the idea that it's a technology, it's going to be on your phone app, isn't true. It's all across the spectrum. Also, too, for our rural health, it's key, is because there's a lot of the access to care, the access to specialty care. So in that model, it's very technology intensive because there's a lot more monitors that need to be used. There's a lot more equipment. So the idea is that we have to make sure that our technology is key in providing that service to them. And there's the continuity of care that Peter touched on. And that's the idea of the physician integration. So it's making sure that those patients, once they're discharged from the hospital, have some type of access to care so they're not entering back into your hospital through the emergency department. So there, it really is making sure that we have the patients, we communicate to them how this telehealth model works, and the physicians are on board. So they're going to send their patients to some type of telehealth model rather than back into the emergency room. And just a brief case study, and where we've looked at is kind of the innovation bell curve, right? You have your early adopters and what's happening. So I bring up this slide just to show that we're still kind of in the early adoption side. So we have our urgent care clinics. We had one of our premier ones. In 3 months, we only spent $100,000 in marketing, and we had 20 patients a day. A lot of the telehealth providers that I've seen, this is the direct-to-consumer, 3 months, a huge marketing budget, and they were just down to 4 patients a day. So the question is telehealth even viable? Is it something for the future? And what I'd like to add, and then there again, I think Peter so eloquently stated, is that it still is new, but it's going to be very much a part because it's the brand building, the systems, we're looking into it because it's just another way for the patient to access care, and they can access care to a way that's through our brand. And that's the direct-to-consumer model. The idea of the population health, too, is that we want to be able to manage those capitated patients. So as with healthcare reform, especially in the Los Angeles market, we're increasingly going to be more responsible for ensuring that there's a reduction in the cost of care to those patients. So it's managing those types of managed care capitated patients. And then the continuum of care, which we've talked about, is just the discharge follow-up, medication management, and for those chronic care patients, the oncology patients, and making sure those patients don't end up back in the hospital. So that's it. I think we have about 5 minutes for question and answers. I want to thank everybody on the panel. Any last words from the group? So I'll open it up to questions.
So since the people here are mostly interested in buildings, are you seeing it, or the folks who are from the providers saying we're going to build smaller now because we think there's going to be, like on the telehealth side, we just don't need as much physical presence?
Well, I will go for it.
Go ahead.
I would say this. In telehealth in general, we don't tie it to technology because my belief is the only thing that moves faster than technology is consumer expectation. And what we're going to be seeing is we got to penetrate into the communities and where they live, right? And so you can't put huge mothership hospitals in every neighborhood. That's just not. I don't think it's just even feasible. The thing is to how do we access them in a convenient way as their expectations are going to be rising, whether that be because of the deductible. So I think it's complementary to the strategy. It's not just we want to lower a cost.
Yeah. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I. Go ahead. Go ahead. I would say this. I mean, I.
I travel all around the country talking to health systems on a weekly basis, and there are very few markets where there's big hospitals being built today, and I don't see that changing. Now, there may be some replacement facilities, and in most cases where there are replacement facilities that were built in the Hilbert, the 40s, 50s, 60s, most of those are downsized from an inpatient bed count perspective. So I don't think there's any question that smaller and distributed will be, where things are built. And to Peter's point, pushing into communities where people, we call it where people work, live, and play, in the sense that that's where they want to get care. If I have an open heart surgery, I'll go wherever you tell me to go, where the best place to be is. If I have a cancer treatment, patients have proven they'll get on planes, not just in cars and in ambulances, but on planes to get the right care in the right setting. But for their every day, every week, every month needs, they want it close to home, and they want it to be on a basis that's convenient. Across all of our markets in the emergency room, right? And we have facilities that see, significant volumes relative to their physical structure. It's 9 minutes door to board certified ER physician. 9 minutes. So in most cases, that means it's 2 or 3 minutes. The more important number is the door to discharge time is 80 minutes. Right? So you compare that to big hospital campuses today, even if you're skewing the number on the front end by sticking someone in the waiting room, which a lot of people do, to report to Medicare. So you triage somebody in the waiting room, they see someone, then you get put back in the waiting room. But those numbers are 1 hour and 4, respectively. 4 hours if you go to the ED, and that's on a pretty good day, in a lot of cases. Now, a lot of those people in the ED don't need to be in the ED. And so that's where all of this begins to be complementary. I think it's going to be, my personal belief is there's no question distributed care footprint is going to win the day. And I think it'll be a longer time coming for people to really sit at their phone at home. Now, whether they sit at a kiosk or at a screen or on their phone with somebody else sitting next to them in a convenient location that's close to their home where they feel comfortable, I think that gets there a lot quicker. But it's all complementary in terms of the continuum of care. And I think there's huge applicability, by the way, on the post-acute side for telehealth, for virtual health. Probably more so than the pre-acute side.
And from the investor standpoint, we are not seeing telehealth replace exam rooms yet. In fact, the footprint might grow larger because they need a telehealth conference room in their space so the physician can see patients in person, but also do consultations over the phone or via Skype. Maybe if you own a 5,000 square foot MOB in a rural area, that's where we see, which Duke doesn't and probably 95% of the developers in this room don't, but maybe those buildings will be replaced by telemedicine. We think it could become the model of care for rural health, but as these guys says, it just supplements the continuum of care in a metropolitan area.
That's why to provide this last slide here is that, I agree, is as far as, the large facilities. So it's Evidence Health, we're the largest rural health provider in the state of California, and that's where we're going to see an opportunity, I guess, as far as your facilities is expanded rooms, higher technology, so you're going to need other facilities to support all that technology that's going in, because there again, it's a much higher acuity need for telehealth in those rural care clinics, so it's not just an app on your phone at that point. There is a lot of equipment that needs to support that virtual care.
You had a question?
Well, it's interesting you talked about telehealth. There's also the other side of the coin. It's like the Cleveland Clinic is, because of now all x-rays are electronic, they've consolidated all their radiologists into one group in one facility, and they specialize. They're just a group of radiologists that all they do is look at mammograms. And what they have found is that by that group being specialized, their identification rate has gone up significantly. significantly higher than if you just look at everything.
We do this, we do the same thing.
Yeah.
We sit
And so
down with our
that's,
health.
like you say, it's changing where the
Yeah.
real estate is and the type of real estate, and it's also changing the numbers significantly.
Yeah, and you're focused then on metrics of delivery, right? Both quality and time.
Driver on the value, too.
Yeah.
The quality of care.
I can't tell you the number of health systems that I've walked into and said, okay, here, and they say, we want you to use our ER physician staffing group, I want you to use our radiologist, we want you to use blah, blah, blah. And my answer is uniformly the same, which is, that's great, here's the expectations from a metric of quality and performance and time. And in, not all, but many of those cases, the radiology groups in particular say, that's not how we do it. That looks hard. Final reads in 30 minutes, non-resident final reads in 30 minutes. That seems really hard. And we say, that's great, but we have a team that does it, and we get average reads on 14 minutes, which, by the way, has a massive influence on your ability to have 80-minute discharge times. So it's asking the why at every step of the way is to, and it's going to take, some places, Scott and White, I mean, academic teaching institution, they reorchestrated their entire imaging protocol, and now every one of the hospitals inside that system gets 30-minute final reads.
I would do one last parting thought. I think from any service line, primary care to any specialty line, virtual health is going to impact it different. We're not going to call it teleradiology. It's called radiology. Pathology is going to be next, and it's going to impact. But going back to the interest of physical buildings and how virtual health, they're getting much more creative, and I think Mayo Clinic is doing a great job of this, is they use a thing called e-consult, and what you see is they go into highly competitive areas, 150, 250 bed, and they say, you'll be part of the Mayo Clinic network, right? So you could brand that. And they just give second opinions, which is a brilliant move because they're not building as much brick and mortars, but they're being able to have a national spread to able to, one, help that community, but also they did this in San Diego Hospital, which was a brilliant play because they're consulting with the physicians, and when they find a tertiary quaternary care patient, why don't you send it to our Arizona market? And so I think you're going to see how virtual health is going to be very creative in how we approach it, and there will be different impacts to the physical buildings.
Any other questions? We're at time.
I just had one quick question for Ryan. You said you've developed 11 of these micro hospitals now over the years. What are some of the lessons learned, or how have those facilities evolved, or, as a developer, what have you learned about those?
I think the biggest lesson learned is the location of these, because they are off campus. You want them to be in absolutely the right location, and limiting our exposure. When we first started this with Ameris, we weren't limiting our exposure, and then as we grew and grew and the portfolio became larger and larger, we had to start limiting our exposure just in case, it is not the wave of the future. But like I said, we are confident it is, and we're excited, and we're still funding these type of development deals.
Yeah, I would say, generally speaking, two things that I've seen, and look, this is a biased opinion, admittedly, but where we've seen health systems, or even frankly some other operators, try to do it on their own, two things happen. They tend to have a general assessment that anywhere within a circle is fine, our brand will win. Give me a narrow circle in an area and we'll win, even if it's not the hard corner. And two, by the time the clinicians are finished, it's gone from 20,000 feet to 80,000 feet, which then puts you no longer in the ability to be at Main and Main because you can't get enough acreage to be at Main and Main. Right? So they kind of tie together, but those are, yeah. I mean, fortunately, I don't think we've made many of those mistakes so far, but that's the common too is, in most of our market, our mature early markets, we're now backfilling. So, we're doing exactly what we talked about is we've got one that's at capacity or over capacity. So we're building another to create another access point and decompress it from a utilization standpoint. Instead of building it 2 or 3 times bigger, waiting for it to fill. So I think those are common more common things that happen across the market.
Any other questions? Thank you so much. It's been a wonderful audience. Thanks for attending.
Likewise.
You gotta catch that 2:30 flight.
I am.
Good luck.
Thank you.
Yeah, thank you. It's one of the best.
Really good. Great meeting you guys. Have a safe trip back. Thank you.
Thank you.
Huh?
Oh,
one
we can't talk about this. We're in trouble.
Oh. Yeah, I just came here last year.
Oh, okay.
Yeah, okay.
So you're in. Oh, okay. Oh, you're real close, actually.
Yeah.
I enjoyed visiting last time.
Very nice presentation. I wanted to introduce Dave Sisak, Dave's our Chief Investment
Hi,
Officer.
Dave. And Vic Schmerbeck. Good
You
to
guys
see
have
you.
talked on the phone.
Yeah, we have.